Welcome to Mercy Medical Center's live webinar about incontinence in men and women. I am Lynn Dennis, the Health Education Coordinator at Mercy. If your computer does not have speakers and you wish to access the toll-free number, click on the additional numbers link under audio. Joining us today are Dan Tucker and Stacy Walrick from Mercy's Urinary Incontinence Center and Men's Health Center. They'll be discussing causes and treatment options for incontinence. After their discussion, they will answer questions from our audience. To submit your questions anytime throughout the discussion, go to the window in the upper right-hand corner of your screen and type in your questions. If you don't see the screen, click on the box, the little orange box with the arrow. Your questions will be completely anonymous and confidential. So let's get started. Dan?
Okay, thank you, Lynn. First of all, Stacy and I would like to welcome you to our webinar today on urinary incontinence, its diagnosis and treatment. First, to talk a little bit about urinary incontinence in both males and females, would like to just discuss a little bit about what urinary incontinence is. There's several different definitions of urinary incontinence, the first of which is as simple as the inability to hold urine in the bladder, or another is the loss of bladder control, or any involuntary leakage of urine. And one thing to remember is that urinary incontinence is a symptom, not a disease. 80% of people who struggle with urinary incontinence can either be helped or cured. One of the problems is, though, is that a lot of patients who struggle with urinary incontinence keep it their best secret, and they don't talk to their physicians or their incontinence clinic about it. So we encourage you to solicit help if that's something that you're struggling with. The various types of incontinence, of which there are 5. The first of which is urge incontinence, and sometimes you hear this referred to as overactive bladder. It is the most common form of incontinence. It's characterized by the sudden need to urinate, and a person can't make it to the bathroom in time. That's urge incontinence or overactive bladder. Secondly is stress incontinence, and with stress incontinence, the patient will have a sudden increase in pressure or stress. The sphincter muscles in this patient with stress incontinence are weak. So things that may cause leakage with a patient with stress incontinence would be laughing, coughing, sneezing, exercising, or lifting, something that creates an increase in pressure. Thirdly is mixed incontinence. And mixed incontinence, by definition, is a combination of the urge and stress incontinence. Overflow incontinence. This is defined by a leaking without sensation of fullness. And in this case, the bladder doesn't empty properly. Now, functional incontinence is you find this in a patient that has difficulty getting to the bathroom because of an illness, example, arthritis, difficulty with mobility, that type of thing would be functional incontinence. There's a lot of different causes of urinary incontinence, and we're going to run through several of those now. Some of them are quite simple and some of them a little bit more complex. The first of which is alcohol. Alcohol, of course, acts as a bladder stimulant and also a diuretic, which can cause an urgent need to urinate. Secondly would be overhydration. This is where a person would have a large intake of fluids, especially in a short period of time, which could cause, in some cases, leakage of urine. The third one is dehydration. In this case, a person who's not consuming enough liquid to stay hydrated. What can happen there is that the urine becomes very concentrated, and concentrated salts can irritate the bladder therefore causing some urinary leakage. Caffeine. Caffeine is a diuretic and a bladder stimulant, so in some cases could cause urinary leakage. Bladder irritation. There's a lot of things that can irritate our bladder, causing leakage. Some of those are carbonated drinks, tea, coffee, with or without caffeine, either way, artificial sweeteners, corn syrup, spicy foods, beverages, sugar, acidic foods, such as citrus and tomatoes. All of those things can be a bladder irritant to some people. Medications. There's certain medications that can precipitate urinary leakage. Heart medications, blood sedatives, muscle relaxants, and others may contribute to bladder control problems. And if they do, you'd want to be sure to discuss that with your physician or your healthcare provider. Urinary tract infections. Infections can irritate the bladder, causing a strong urge to urinate. Signs and symptoms of a urinary tract infection would include a burning sensation when you urinate and or foul-smelling urine. Constipation. Because the rectum is located near the bladder and shares many of the same nerve supply, hard compacted stool in the rectum can cause these nerves to become overactive and can then increase urinary frequency. Obstruction. A tumor anywhere along your urinary tract can obstruct the normal flow of urine, and this would usually cause the type of incontinence we refer to as overflow incontinence. Urinary stones. Stones can form in the bladder, in the kidneys, in the ureters, and in this case, if there's stones present, this could cause a leakage of urine as well. Neurological disorders, such as multiple sclerosis, Parkinson's disease, stroke, brain tumors, spinal injury. Any of these may interfere with nerve signals which are involved in bladder control, and these can cause some urinary incontinence or urinary leakage. Also, aging. Aging of the bladder muscle leads to a decrease in the bladder's capacity to store urine and may increase overactive bladder symptoms. That bladder muscle is called the detrusor muscle, and it's the muscle that has a lot to do with our bladder emptying properly. Prostatitis in men. A loss of bladder control is a typical sign of prostatitis, but incontinence sometimes does occur in men who might have prostatitis, which is an infection or inflammation of the prostate gland. Benign prostatic hyperplasia or hypertrophy, referred to as BPH. The prostate may enlarge in men, and many times does, in men from the age of 40 and up. It's just sort of a natural overgrowth of the prostate gland. In some cases with BPH, there will be some urinary leakage present. We'll talk more about that in a little bit. Prostate cancer, stress incontinence or urge incontinence can be associated with untreated prostate cancer. Most often, though, incontinence with prostate cancer tends to be a side effect of the treatment, whether it be surgery or radiation for prostate cancer. A little bit about the prostate gland in the male. The prostate gland is slightly larger than a walnut when it's normal size, but it gradually starts to enlarge in men, in some men anyway, over the age of 40. The prostate gland is located, its location is that it surrounds the urethra. just below the bladder. So with the urethra, how we empty our urine passing through the prostate gland, if the prostate gland starts to enlarge, it can inhibit the flow of urine outside of the body. The function of the male prostate gland is to store and secrete a clear fluid that, along with sperm, constitutes semen. It contains smooth muscle, which helps to expel semen during ejaculation. It releases secretions that keep the lining of the urethra moist. It is not just a gland. We refer to it as the prostate gland, but it is both a muscle and a gland. And it produces the protein PSA, which we hear a lot about. Prostate-specific antigen is what PSA stands for. Male stress incontinence. For men who have had prostate surgery, one thing that has proved to be beneficial is a collagen injection. And this is an injection to the urethra area, and it creates a resistance and therefore helps with the leakage of urine. And we'll talk more about collagen injection in a little bit. Also, a sling procedure. Sling procedure is a surgical procedure, works both for men and women, and has about a 70% positive outcome in both men and women. Now, male overactive bladder is one and the same as urge incontinence, which we talked about earlier. Oftentimes in men, it's caused by an enlarged prostate, which we just talked about the prostate gland a little bit. About 60 to 70% of the time, opening up the prostate gland improves symptoms. When I say opening up, there's a couple procedures. One's called a TURP, that's a transurethral resection of the prostate, or a TUVP, which is a transurethral vaporization of the prostate. Sometimes you hear a slang term, they refer to it as a Roto-Rooter procedure. 30% of the time, medications will help the patient if the TURP or the TUVP doesn't solve the problem. And the type of medications that would be used in this case would be from the class we refer to as anticholinergics. Female stress incontinence. The female bladder is supported by the pelvic floor muscles, the vagina, and certain ligaments. Over time, these structures may weaken, moving structures downward, preventing the pelvic muscles from squeezing tightly enough to keep the urethra closed. In this case, then, there would be urine leakage with physical stress. And by physical stress, again, with female stress incontinence, we're referring to things like lifting, coughing, sneezing, and exercise, those types of things that increase the pressure. The stress incontinence, again, with the female, most common in women less than 75 years of age. And again, characterized by increased abdominal pressure from sneezing, coughing, lifting, etc. 85% of the time, it's caused by hypermotility of the bladder neck, which is associated with aging, hormonal changes, trauma, childbirth, and pelvic surgery. And what we mean by hypermotility of the bladder neck is the urethra fails to close and becomes overly movable or hypermodal. 15% of the time, female stress incontinence is caused by sphincter problems, usually related to pelvic radiation and certain neurogenic causes. Overactive bladder symptoms, frequency, urgency, and urge. Frequency, problem urination, if this is with a person that has to urinate 8 or more times per day or 2 or more times at night. Urgency, this person would have a sudden strong need to urinate. And urge, leakage or gushing of urine followed by a sudden strong urge would characterize symptoms related to overactive bladder. Diagnosis. In our urinary incontinence center here at Mercy Medical Center, we do assessments with our patients, both male and female patients. The assessments are conducted by urologists. About 80% of our patients are female and 20% approximately are male. The way our assessment process works is we get a patient history, an incontinence history, and 2 days of bladder diary. And this is attained prior to the patient's visit here in our incontinence center. And then they bring that information in with them when they come for their visit. And our assessments take approximately 15 to 30 minutes, like I said, done by the urologist. Sometimes additional testing is required for the physician to have the information needed to make an appropriate diagnosis for what the incontinence situation is for that particular patient. Therefore, we do what we call urodynamic testing here in our center. There is urodynamic testing and there's video urodynamic testing, and we do both here. What urodynamic testing is the study and documentation of the factors involved in filling, storage, transportation, and evacuation of urine. It does all types of measures. It measures flow rates, bladder capacity, bladder pressure, abdominal pressure, detrusor pressure, the big muscle over the top of the bladder. It'll show us leak points, urethral pressure, and we can also take video of filling and emptying of the bladder if the physician orders the video portion. Testing that's a part of urodynamic testing includes something called a uroflow, cystometrogram, flow pressure, and EMG. And again, this gives the physician the specific info that they need to treat, to diagnose and treat the patient's incontinence problem. It provides them with printouts of much information about pressures and volumes and such, which then the physician can sit down and look at and make determinations of how to best treat the patient. Male incontinence treatments. The simplest of which would be bladder training, which is simply limiting fluids and helping the patient to plan regular trips to the bathroom. There's Kegels exercises, which strengthen the pelvic floor muscles, which Stacy's going to talk more about in a few minutes here. And then there's medications. The medications for male incontinence do one of two things. They either open the channel or shrink the gland, meaning where the urethra passes through the prostate, it either helps to open that up so the urine can flow through there, or the medication in some cases will shrink the prostate gland so then it's not squeezing on the urethra, causing a problem with the patient passing urine. Under medications, one grouping is a group called alpha blockers, and what these do is relax smooth muscle, allowing for normal urine flow and preventing abnormal contractions of the bladder. There's many different medications you may have heard of out there. One is Hytrin, Cardura, Flomax, Uroxetrol. Those are examples of alpha blockers. Then there is Proscar and Avodart, which work to shrink and enlarge prostate gland. Tofranol relaxes muscles and blocks nerve signals, which may cause bladder spasms. And then there's the group called antispasmodics, which relax the bladder muscle and relieve spasms. Some examples of antispasmodics are probanthine, Detrol LA, Ditropan XL, Enablex, Sanctura, and Vesicare. Female incontinence treatments. Just as with the men, we talked about bladder training. Also, lifestyle changes may be appropriate in some cases. It might be something as simple as a weight, diet, etc. There's many things involved there. Physical therapy, the Kegel's exercises and the biofeedback, which again Stacy will talk more about. Medications, and then there's surgical interventions for female incontinence. And surgery tends to cure 4 out of 5 cases, but what the statistics have shown is that the success rate drops about 50% after 10 years with surgical intervention for female incontinence. Some surgical solutions, collagen injections are one. These are injections of collagen into the urinary sphincter, and what it does is it plumps up and strengthens the sphincter, helping the sphincter to close off when it's supposed to close off, and therefore eliminating or diminishing leakage. The collagen injections tend to be done in the physician's office, and with collagen injections, many patients will find that it needs to be repeated. The injection needs to be repeated every 6 to 18 months. It just depends on each patient, though. There's a surgical procedure called a sling procedure, and in this case, this is done in the operating room, of course. It's a created support for the urethra by wrapping material around the urethra and attaching it to the pelvic bone. What this does then is keep pressure on the urethra so it doesn't open until the person consciously releases it. So that's a sling procedure, and that procedure can be done either on a male or female. Artificial sphincter, this is for male only. There's a pump balloon and sphincter that can be implanted in a male, and this is for severe incontinence, and in this case, this is for a patient where nothing else has really been able to help the patient. Some medications for female incontinence, urge incontinence, are the biggest group we see are the anticholinergics. What the anticholinergics do is relax bladder muscles. They prevent spasms, increase bladder capacity, and delay the initial urge. Does have some side effects associated with, and some of those are dry mouth, headache, and constipation with the anticholinergics. Some examples of the anticholinergics then are probanthine, ditropan, oxetrol, detrol, Levbid, Sanctura, Enablex, Vesicare, and Toviaz. For female stress incontinence, there is a medication out there called Catapress, or clonidine is another name for it. It's a medication that falls into the category of alpha-adrenergic agonist, kind of a big word there, but that's the category that Catapress falls under. And what Catapress does is strengthens smooth muscle at the internal sphincter site. It's been found through the statistics that the benefit has been shown to be minimal in most females, and there are a number of side effects associated with Catapress. For urge incontinence, neuromodulation. This is, and again, urge incontinence, one of the same as overactive bladder. In our area, interstim is also known by the name of interstim. Neuromodulation is the process of stimulating nerves leaving the spine, which go to the bladder. This is it's done at the sacral level. It's called sacral nerve stimulation. It is effective in some patients, particularly those who have tried other treatments and haven't had any success. It's first tested with an external generator and a lead that goes into the sacrum, and it's tested for a period of time to be sure it's going to work for the patient. And then if it does provide positive results, then they take the patient to the operating room and they implant the generator and the permanent lead in either to the upper buttock or the abdomen area. It is an expensive treatment, but it is covered by Medicare. For stress incontinence in females, surgical, there is a procedure called the Birch procedure. It is a bladder neck suspension procedure. Most of the time you see it done as an open procedure over the years, but there is a laparoscopic Birch procedure available as well. And what the Birch procedure does is it secures sutures to the ligaments to support the urethral sphincter. That's the Birch procedure. Surgical for stress incontinence in females. We talked a little bit earlier about the sling procedure. This is the most common surgical procedure being used today for stress incontinence. It's a vaginal incision. They can either use a fascial sling, which is a part of the patient's own body, fascia, or a synthetic sling. There's a couple of different types out there. There's one called TVT, or transvaginal tapes, or one called a TOT, which is a transobturator tape. And both of those are available, and both of those are of the synthetic variety. And what these do is they support the urethra and give the patient relief from their urinary leakage. And now I would like to move forward into the physical therapy part of the program. I'm going to turn it over to Stacy.
Thank you, Dan. Like I said before, my name is Stacy Walrick. I'm a physical therapist here at Mercy Medical Center and am able to work with patients that have urinary incontinence. With physical therapy, we can treat both male and females with physical therapy. Can also treat both stress and urge incontinence or a combination of both. Typically, it's almost more common to see patients with a combination of both stress and urge incontinence, and we can treat the combination. Physical therapy can be used alone or can be used in conjunction with medications, the nerve stimulation or neuromodulation, or before or after surgery. Physical therapy includes a combination of exercises, lifestyle changes, biofeedback, electrical stimulation, and patient education to help strengthen the pelvic floor and improve control. The exercises that we would do in physical therapy will help to strengthen the pelvic floor. We use both the pelvic floor muscles and hip musculature to help increase the strength and stability of the pelvic floor. The pelvic floor is a very thin layer of tissue. It sits like a hammock under the pelvis, connected at the front at the pubic bone and all the way to the back to the tailbone, and also side to side. The tissue is a combination of both muscle tissue and connective tissue, which is supported by ligaments and internal structures. The thickness of the pelvic floor changes throughout our aging process. When you're in your 20s, it's about 5 tissue paper layers thick, and following any childbirth, menopause surgeries, the thickness can be more like 1 tissue paper layer thick that has been very fragile. So it's difficult to hold up all the internal structures when the tissue is that thin. The tissue quality declines, like I said, after childbirth, surgery, menopause, hormonal changes, and gravity. The Kegel muscles, or pelvic floor contractions, are exercises to help strengthen the pelvic floor. They involve trying to tighten the pelvic floor as you would if you were to try to stop the flow of your urine. We like to work on holding the pelvic floor contractions up to 10 seconds, as well as doing quick contractions. We try to limit the use of our abdominal and gluteal muscles while we are doing the Kegel exercises to be able to isolate the pelvic floor muscles. Like I was saying before, since the thickness of the pelvic floor is very thin and also has a combination of muscle and connective tissue, we like to utilize other muscle groups to help strengthen as well. The hip muscles connect onto the pelvic floor and onto the ligaments that support the pelvic floor. So by using that muscle group, we can help to strengthen and support the pelvic floor also. There are many nerve endings and reflex loops associated with the pelvic floor and bladder, and these have a strong connection with our nervous system. Normal continence is under our unconscious control. Problems arise when our parasympathetic nervous system becomes too in control and it increases stimulation to the area, this can cause some of the increased urgency, frequency, and difficulty knowing how full the bladder is, and these can lead to the incontinence symptoms. Our breathing diaphragm is also an important structure. It has a lot of nerve endings and reflex loops as well that are in connection with the pelvic floor. So a lot of the exercises also can involve some breathing exercises to help control the pelvic floor. Along with having a uterus or having the uterus removed or hysterectomy, that can influence the support and structure of our pelvic floor as well. And so women that have had that at times can expect problems in the future, but not always. Biofeedback is one tool that we can use in physical therapy. What it is an internal sensor that helps detect muscle activity of the pelvic floor. We utilize biofeedback to help teach patients how to perform these exercises correctly. Sometimes patients don't quite understand how to perform the Kegel exercise, and this can help teach them. The biofeedback assists with muscle training as well as neuromuscular control. It helps us to avoid recruiting other muscle groups instead of the pelvic floor muscles. The biofeedback is hooked to a computer screen, and what it does is provides visual feedback on how our muscle activity is working. And so for people that are visual learners, that helps as well. The biofeedback helps us to monitor the progress as well. If we perform it in repeated sessions, we can see how their progress is going. Biofeedback is a painless procedure. There just may be some slight discomfort from the sensor, but it only lasts as long as it is in. Physical therapy also discusses with patients some of the lifestyle modifications. Dan talked about a few of these. The big thing is diet. We really encourage patients to avoid caffeine, aspartame, alcohol, and acidic foods. Like he said, these really irritate the bladder as well as stimulate the nervous system, leading to the increased frequency or urgency symptoms. We also teach patients to drink plenty of water, the 6 to 8 glasses of water per day to help stay hydrated and to help dilute the urine so it's less irritable in the bladder. Making sure people have plenty of fiber to stay regular because the constipation can help make the symptoms worse. Activity levels and exercise programs are also important. We like people to stay active and participate in daily walking, biking, swimming, or yoga classes, partially for the aerobic activity, but also for the stress reduction and taking the mind off of all of our daily stresses. We also encourage the elderly to try to stay active and as mobile as possible. When the elderly can stay up and walking, it makes normal continence system kind of work better. When they become less active and stay in the chair or the bed all day, then it leads to more symptoms of incontinence. Breathing and relaxation exercises are something we teach to try to help relax the bladder as well as relax the nervous system. This can help decrease the irritability and frequency with the bladder. Smoking cessation is important as well. As we all know, smoking can affect our tissue health and healing, and so can compromise the health and integrity of the pelvic floor tissues and structures as well. Clothing can be a possible modification for some people. We encourage people to wear loose-fitting clothing to help be able to remove easier, especially if they have the urgency symptoms. It's hard to fumble with a belt and a complicated button or zipper to try to make it to the toilet in time. Also, wearing too tight of a belt or pants around the abdomen can put increased pressure on the bladder, which can also lead to increased symptoms of leaking. A nighttime routine can be important for patients that have increased frequency of urination at night. We tell patients to avoid fluids after 7 p.m., depending on what time their usual bedtime is, and to especially try to limit caffeine. Performing breathing and relaxation activities for about 15 minutes prior to their bedtime, and then to avoid before they go to sleep. This can help ensure that our bladder stays quiet and that we're emptying it fully before we go to sleep. And then our mental status is also important as well. Patients that start to develop dementia are going to have a harder time with incontinence as well, but partially because their brain's just not quite telling them that they need to get up and go. So physical therapy for stress incontinence, our goals are to help increase the pelvic floor strength and stability through the exercises to make sure that our clothing is not too tight. It's important to use proper protection when you have any leakage, whether it needs to be a thin panty liner or more of an incontinence pad. And it's also important to change it frequent enough. Sitting in a wet pad or wet underwear can irritate the skin and tissue there too, which is not good. With stress incontinence, decreasing caffeine and increasing water consumption is important, and making sure you get a regular aerobic activity. With those pelvic floor exercises for patients with stress incontinence, we work to try to keep the abdominal muscles quiet and relaxed while we're working the pelvic floor muscles. If we tighten the stomach muscles too much, it can increase pressure onto the bladder, which can force some of the leakage out. So that's why we try to keep the stomach quiet while we're working the pelvic floor muscles. Specific treatments for urge incontinence, also to encourage the no caffeine, alcohol, or aspartame, and to increase the water consumption. The breathing and relaxation exercises can really help with the urge symptoms to try to decrease that stimulation of the nervous system. Performing the pelvic floor exercises can help increase the strength of the pelvic floor so that you can overcome the urge. We also like patients to work on increasing their time in between urinations and try to avoid going every 30 minutes and trying to increase normal voiding time to every 2 to 3 hours. Proper fitting clothing can be important as well, making sure you can get the clothing off in time to make it to the bathroom, and as well as the regular aerobic activity. Tips for patients when they do get the urge to go is to stand or sit calmly and quietly. You can perform several of the quick pelvic floor contractions, or you can roll your knees in and out with or without resistance. Try to take slow, deep breaths and try to stay relaxed, and take your attention off of the bladder urge and try to focus on something else. When the urge passes, you can continue with your previous activity. When the symptoms return, kind of go through those tips again. If it's been greater than 2 to 3 hours, then you can slowly and calmly walk to the bathroom to avoid the bladder. Research has been a good support for physical therapy, whether it's on its own or in combination with other treatments. One study found that the combination of pelvic floor muscle rehabilitation and percutaneous tibial nerve stimulation found 88% of the patients were successfully treated and dry. That was by Surwitt in 2009. Another study, the Cochrane Reviews, supports pelvic floor muscle training as the first-line conservative management for women with stress, urge, or mixed urinary incontinence. That was by Karen in 2009. Another study found that decreasing caffeine intake by 50% can reduce episodes of leaking by 57%, and that was also by Karen in 2009. Physical therapy services can also assist patients that have prolapsed uterus or cystocele, and that may have incontinence symptoms or may not. They can help with patients pre or post-pregnancy. Same thing whether they have incontinence symptoms or to help prevent them from coming on in the future. Some athletes may experience some stress incontinence when they're doing a lot of running or jumping activities, and that can help treat that as well, as well as prevent that from happening in the future. Physical therapy can assist with some pelvic pain disorders, or can help with children that are having leaking issues or bedtime wetting. Physical therapy can also help with some of the neurologic disorders that have incontinence, such as multiple sclerosis or Parkinson's disease. In conclusion, if you think you may have urinary incontinence or have symptoms, we just encourage patients to openly discuss their symptoms with their physician or healthcare provider, and to help explore their treatment options. And as Dan mentioned, there's quite a few treatment options out there, so just have to take the first step in saying something to your doctor. Well, thank you. This is the end of our presentation, and if anybody has any questions they'd like to write in, we'd be more than happy to answer any of them.
Thank you, Dan and Stacy. And to remind our audience that your questions can be submitted from the box in the upper right-hand corner of your screen. The questions are completely confidential, private. If you don't see the screen, click on the orange box with the white arrow. Our first question today, do I need a referral to come to the Incontinence Center?
Well, I could go ahead and take that one. No, you do not. In our Incontinence Center here at Mercy Medical Center, you can come in with a referral from your physician, or you can come in as a self-referral. You just call our Incontinence Center, and I actually do the scheduling, and we can just schedule you in without a referral. No referral needed. And I just like to add that about 80% of folks out there who are struggling with urinary incontinence can either be helped or cured. So as I think I mentioned at the beginning, I just encourage people not to keep it their little secret, but to know there's help out there. And so come and see us. Thank you.
With physical therapy, we do need a physician order, and typically your family physician or your OBGYN or urologist is typically usually happy to give you an order for that. But if you give Dan a call, he can discuss that with you if we need one or not.
I think our next question would be for Stacy. What is the proper way to do Kegels?
I get that question quite a bit. Most people are not quite sure if they're doing it correctly. Typically, the cues I give patients are to try to tighten their pelvic floor as if they were trying to stop the flow of your urine. So if you were trying to go to the bathroom and you try to tighten the muscles that kind of sit on the bottom of your pelvis to try to stop the urine flow. Like I said, it's trying not to use your stomach muscles and trying not to use your buttocks muscles. It's trying just to tighten that inside muscle there.
A follow-up question to that, is it more effective to do the Kegel exercises in a standing or a sitting position?
It is going to be more difficult to perform the Kegel exercises standing versus sitting. So the easiest way to do them is going to be actually laying down on your back or on your stomach because gravity is not going to be affecting the activity of the pelvic floor. Sitting is going to be the next difficult. Standing is going to be harder than sitting. So, starting out doing them whichever position and then kind of making the increasing challenges as you can handle them. And then the next step then is kind of adding them as you do transitional movements, such as if you're going from sitting to standing or from, rolling over in bed or even walking and trying to hold it for a couple of seconds. So that's a good question.
Next question, what is the recovery time for the sling procedure?
Actually, it's very short because it's actually done sometimes under a local. The recovery time is very quick in the hospital stay. Sometimes go home the same day or stay maybe one day in the hospital post-procedure. So that's one of the benefits of the sling procedure is quick recovery and getting back to your regular activities of life.
I want to remind everyone that a tape of this program will be available at www.mercycare/ and encourage you to watch this site for additional future webinars. I believe we may have covered all our questions. Additional questions, though, you can contact either Stacy or Dan at 319-861-7874. And we thank you for joining us today.